We move to the next speaker. I'd like to introduce Professor Laurent Pierrot, and because he busy in US now, and so we have a record of presentation about the topic acute flow diverter in the future of aneurysm treatment. Professor Laurent Pierrot is come from the Reims University Hospital. Please.
Good morning, everybody. Thank you for the very kind invitation to participate to the Vietnamese Society of Radiology and Nuclear Medicine Congress. Thank you to Professor Pham Minh Tong and Vidong Lu for inviting me. So I will discuss now the topic, are coated flow diverter the future of aneurysm treatment? So here are my disclosures. So flow diversion. Flow diversion has some strengths and some weaknesses. So it is really important to consider before discussing coated flow diverter. So when we look at the indication of flow diversion, due to its high efficacy, flow diversion is increasingly used in the endovascular management of intracranial aneurysm. At the beginning, the initial indication for flow diversion were large and giant ICA aneurysm and recanalized aneurysm. And there was a progressive extension to small IC aneurysm, distal aneurysm, and bifurcation aneurysm. Okay, there is still some debates regarding the usefulness of flow diverter in the treatment of posterior circulation aneurysm, and also to some extent in the treatment of bifurcation aneurysm. But let's say that due to its very high efficacy, flow diversion is more and more used for the treatment of intracranial aneurysm. But in the same time, flow diversion has a main limitation, which is the need for dual antiplatelet treatment to prevent acute intrastent thrombosis, delayed intrastent thrombosis, perforators and side branches occlusion, and distal emboli, let's say to prevent thromboembolic complication. So one way to avoid dual antiplatelet therapy is to modify the surface of the flow diverter, to reduce platelet aggregation. So Phenox was creating a coating whose name is hydrophilic polymer coating, HPC. It is a glycocalyx-like surface that it's placed on the flow diverter, and which will inhibit platelet aggregation on the flow diverter. So, and it will theoretically prevent platelet aggregation. There were some tests on the bench, in animals, and it works. So now we need to have an evaluation in a clinical condition. So we have some preliminary results. I was publishing with a team of Lyon, with a team of Professor America in Lyon, preliminary evaluation of P48 MWHPC plus dual antiplatelet therapy. You see that we were recruiting 28 patients, 29 aneurysm between April 2019 and May 2020. You see the location of aneurysm is quite classical, but a lot of bifurcation aneurysm, ACOM, MCA. You see that most aneurysm were rupture or recanalized. Treatment feasibility was 100%. All patients were treated with flow diverter, P48 HPC. There were some intraoperative complications, no intraoperative rupture, but 2 thromboembolic complications, but without clinical worsening. Morbid mortality at 1 month was 0%, and you see that the rate of complete occlusion at 6 months was 87%. There was also and it is under publication by the team of Professor Hans Henkes in Stuttgart, Germany. There was the treatment of patients with P64MW HPC, so the coated flow diverter, plus single antiplatelet therapy in 100 patients, 128 aneurysm. The single antiplatelet therapy was prasugrel. There was a technical success in 100%. The rate of complete or near complete aneurysm occlusion at 4 months was 75%, at 9 months 88%, and there was no morbidity or no mortality. There were some intra-procedural complications, but you see that there was no thromboembolic complication or hemorrhagic complication. There were some technical problems, flow diverter foreshortening, flow diverter collapses, and there was one ICA dissection. There were also post-procedural complications with ischemia in 4 cases in jailed MCA branches. There were some instant thrombosis in 2 cases, which is not too much, by the way, and there was a foreign body reaction in 1 case. And finally, there was delayed complication and parenchymal hemorrhage, so after 30 days in 1 patient. So you see that the rate of complication is quite acceptable and in line with what we have with bare flow diverter and dual antiplatelet therapy. So to evaluate properly the P64MW HPC flow diverter, we have built the cutting study. So cutting is a study, is cutting to optimize aneurysm treatment in the new flow diverter generation. It's a European multi-center prospective randomized controlled trial comparing aneurysm treatment with a bare P64MW flow diverter under dual antiplatelet treatment with aneurysm treatment with coated P64MW HPC under single antiplatelet treatment. So the study design, the primary objective is to assess the safety and the efficacy of P64MW HPC under single antiplatelet treatment compared to P64MW bare under dual antiplatelet therapy in patients with unruptured or recanalized aneurysm. The primary hypothesis is that the treatment with coated flow diverter under single antiplatelet treatment is non-inferior to the treatment with a bare flow diverter under dual antiplatelet treatment. And the secondary hypothesis, and we can do that because we have an adaptive design of the study, is that the use of coated flow diverter P64MW HPC under single antiplatelet treatment is superior to the use of P64MW bare under dual antiplatelet treatment. The primary study endpoint is quite original. It is based on the evaluation of thromboembolic complication with diffusion-weighted imaging, assessed 48 hours after the index procedure using MRI. So I just show you an example of that. You see it's a ruptured aneurysm treated in 2010, recanalization, treatment with additional coils and P48MW HPC 3x15. Final result at the end of the procedure, and you see we always do MRI after the procedure to depict these small spots which are the witness of some small thromboembolic complications. So it's what we are looking for in cutting study. So we have a lot of secondary study endpoints in terms of safety, indeed, morbid mortality, the rate of neurological death or major stroke, 6 months and 1 year after the procedure, etc., etc. Very usual secondary endpoint for a flow diversion study. We have also secondary study endpoints for the efficacy of the flow diverter. We have the rate of successful device development, the rate of complete aneurysm occlusion at 6 months and 1 year, the rate of target aneurysm recurrence at 6 months and 1 year, the rate of aneurysm retreatment at 6 months and 1 year, the rate of intrastent stenosis or thrombosis at 6 months and 1 year, and also the mean length of hospital stay after the procedure. The number of patients expected in a cutting study is 200 patients max, 100 per randomization arm. We will have a maximum of 25 centers in 6 countries: France, Germany, Italy, United Kingdom, and Switzerland and Israel. So the study timelines. The plain enrollment period per site is 12 months. The plain study duration is 36 months. You know, the first patient in was supposed to be Q3 2021, and it was the case. And the last patient out is supposed to be in Q1 2024. So there will be an interim report at Q3 2022 after 50% enrollment. And enrollment effectively started in August 2021 in France, in my center, by the way. So inclusion-exclusion criteria, okay, the study is dedicated to saccular, unruptured or recanalized intracranial aneurysm. In case of ruptured aneurysm, you can include the patient if, you know, the rupture occurred more than 30 days before the index procedure. The patient is intended to be treated for only one target aneurysm, except for segmental disease. Segmental disease is when you have several aneurysms on the same arterial segment. Indeed, we have some inclusion criteria regarding the size of the parent artery, which has to be between 1.5 and 5 millimeter. We have also, we need indeed to have a written informed consent, and we only include patients with a clinical good shape, with a good clinical shape before the procedure, with the MRS inferior or equal to 2. Exclusion criteria, one important exclusion criteria is that patients who are currently under long-lasting antiplatelet or anticoagulation medication are excluded because it can change the results. Indeed, if for patients who had recent surgery, recent intracranial hemorrhage, recent subarachnoid hemorrhage, recent is in the last 30 days, they have to be excluded. And indeed, if the target aneurysm was previously treated with a stent or a flow diverter, they have to be excluded. Also, as usual, we are excluding blister-like aneurysm, fusiform aneurysm, dissecting aneurysm, or aneurysm associated with brain arteriovenous malformation. And we have also a contraindication in case of stenting of the ipsilateral carotid artery at the level of, at the cervical level. So, what is the process for randomization? As soon as we have assessed the eligibility criteria and we have the informed consent, you know, we will randomize. It is a 1.1 1-to-1 randomization. So you can be randomized P64 MWHPC with SSPT, only prasugrel or ticagrelor. And if you are in this arm, you will have a single antiplatelet treatment with one of these 2 medications for 6 months. And thereafter, you will stop the medication after 6 months and you will continue with aspirin. In the second arm, P64MW, we will use DAPT, dual antiplatelet treatment, prasugrel or ticagrelor plus aspirin. You will have this treatment for 6 months, and after 6 months, you will stop prasugrel or ticagrelor and continue for aspirin for at least 6 months. So, management of the trial, the steering committee, I am the PI, Professor Cognard and Spell and Dr. Lamine in UK are the other members of the steering committee. We have independent expert groups. We have a DMC group with Jens Filler, Hubert de Salle, Chiaccherini in US, who is a statistician, and Schramm in Germany. We have a CEC to adjudicate neurological events with Professor Ebreto in France, Saris in Germany, and Fischer in Switzerland. We have a core lab, independent core lab with Frédéric Clarençon in France and Engelhorn in Germany. The current status of the study, you see that enrollment started in France, not in September, but end of August. In Germany, there was a ethics committee approval in March 2022, and centers will open soon. In UK, it is, the study is submitted to the ethics committee, and we wait for final approval. And for other countries, Switzerland, Israel, and Italy, we are doing currently the regulatory process. So the current status, study status, you see that all centers in France are open. So 3 centers already enrolled patients. You see, we are treating in Reims 9 patients. In Lyon, there were 9 patients also included, but only 4 treated already. And in Bicêtre, in Paris, there were 8 patients with 3 patients already treated. And other centers are waiting for inclusion or opting. So here you see the enrollment status in comparison with the forecast, and you see that we exactly follow the line of expected inclusion. So in conclusion, flow diversion was of the major endovascular treatment for the management of unruptured and recognized aneurysm due to its high efficacy. Surface modification of flow diverter will potentially decrease platelet aggregation and thromboembolic complication and permit to use SAPT. Surface modification will potentially permit the treatment of ruptured aneurysm. So cutting is the first multicenter RCT comparing bare flow diverter plus gel antiplatelet treatment with coated flow diverter, P64 MWHPC with single antiplatelet therapy. Thank you for your attention.